then mean surgery, cutting me up and having to remove them?
Yes. If we would look, there are some surgical treatment options. The first one we could probably mention is an operation called myomectomy, and now that means removing the fibroid but preserving the uterus. Now that's an operation which is very suitable for younger women who are very keen to keep their fertility, and so, for example, they might be thinking of getting a baby. And we find that women who have had a myomectomy to remove a fibroid, it doesn't seem to cause big problems with fertility, and in fact it can improve fertility. There is some research to say that if we remove a fibroid surgically, it can actually help with a fertility problem. So that's an important option for perhaps younger women, say somebody in their early or mid-30s who still wants to get a baby. The way of doing the myomectomy, again, can vary depending on the circumstances. So we have the traditional surgery, which is a cut in your tummy, which involves a few days in hospital and then a few weeks of recovery. But that's a perfectly good operation, and it's a very common gynecological operation that is done. We have some newer technology for that, so there's a possibility of doing that surgery via laparoscopy, which is making a little cut in the navel and 2 or 3 little cuts lower down in the tummy and blowing the tummy with gas and doing everything through a telescope.
Okay.
So the advantage of those procedures is that the recovery is much quicker, so it might be 1 or 2 nights in hospital and a quicker return to normal function. So that's a good surgical option, which is also available now. And then thirdly, for myomectomy, where the fibroid is very close to the lining of the uterus, there's another surgical option called hysteroscopy, or hysteroscopic resection, which is another telescope going through the vagina, through the cervix, inside the uterus, so not cutting in the tummy, but doing everything from inside. And that's particularly good when the fibroid is close to the lining of the uterus and maybe causing period problems. And that, again, that surgery is might even be done as a day case kind of arrangement, or 1 night in hospital, and again the recovery is very quick after that type of surgery. So we have those surgical options, which are very much, it's a matter of tailoring the right type of myomectomy to the right patient. For somebody who's completed their family and is maybe thinking, well, I've got this problem, I've finished, I don't want any more babies, and now I'm looking forward to another 20 years of awful periods, or 15 years of awful periods. Hysterectomy is probably a good option because that gets rid of periods completely. We leave the ovaries alone, so hormonally things don't change. Sexual function is normal after hysterectomy, and so that's a very good option for people who feel that they've had enough and they just want to get rid of periods completely, and that's also a good option. And again, as with the myomectomy, it can be done as a cut in your tummy. There's a vaginal hysterectomy when the uterus is not so big, and also various laparoscopic ways of doing it as well. So as time goes on, we, as gynecologists, we keep inventing new ways of doing these things.
And that are less painful and stressful.
Well, that's the general idea. The emphasis is to try and get a procedure with a recovery time, less time in hospital and a shorter recovery time as the technology evolves. That's the way that we're moving.
Now that there are no symptoms, I mean, that they're not that serious, if you can call them that, should I then, every time I go see a gynecologist, ask him to check for fibroids?
Well, it is part of the routine check that a doctor would do. Not even a specialist necessarily needs to do that. So, for example, we're always encouraging women to go for pap smears as a screening test to detect changes that might lead to cancer of the cervix. And during that pap smear, we usually do a check of the size of the uterus just to make sure that there isn't a problem there. So that's very much part of a routine checkup that can be done even by our nursing colleagues or by a general doctor. It doesn't even need to have to be necessarily a specialist or a gynecologist. But yes, that's very much part of the routine check.
And then what are the chances of fibroids recurring once I have them removed?
So after hysterectomy, which is removing the uterus, we can guarantee 100% that they're not going to come back.
It's a done deal. Yes, it's a done deal.
There's no doubt about that. With myomectomy, which is removing the fibroids but preserving the uterus, there is a chance of them recurring. And indeed, in my clinic, I do see quite a lot of patients in that kind of situation, that maybe they had a myomectomy 5 years ago, and now the fibroids have come back, and they're looking for a non-surgical procedure because they think, well, I don't really want to have another operation. So that is a problem with myomectomy, that there is a chance of the fibroids recurring. So which is when really brings us to to our newer option of non-surgical treatment.
Yes. the UFE.
Uterine fibroid embolization.
Okay.
UFE for short.
Yes, you. Now, Florence, for example, if she has a daughter, what are the chances of her daughter getting fibroids? Is it linked genetically?
There is some family connection, yes, you're right. It's not an inevitable thing that because I had it, my daughter must inevitably get it, but there certainly is a connection. It does run in families, yes.
And are you, how do you feel now that you're done with that? Of course, the tummy is gone, the large swelling, but now you have awareness, right?
Now I have awareness, and actually initially what scared me when I first saw my first gynecologist, and he recommended removal of the fibroids, but not guaranteeing that this is not going to recur, and she advised that even during the process of removal of the fibroids, they might end up just removing my uterus because the fibroids were too big. That scared me, and I never went back.
Yes.
And I lived with it, and with the help of my husband, he said there must be surely another option.
Yes.
We'll keep trying other option. But every gynecologist, I jumped from one gynecologist to another, looking for a solution, and I wasn't getting any solution until I visited the Kakan hospital, and I met Professor Stones, and he gave me a lot of encouragement to say that if it's not giving you any problems in terms of causing other side effects, we can monitor how the fibroids are and check my hemoglobin, and then we look for an option, because I was not going for removal of my uterus. Even if I'm done with the children, I still felt, as a woman, this is part of me.
Part of you, yes.
And I wasn't prepared to do that. So I battled with it, and eventually that's when Professor Stone said this other option. And of course, I researched on it, and he helped me a lot to understand it. And that's when I went for that option. And to be honest with you, I was shocked because I felt lighter.
Yes.
And I was saying, surely this should have come earlier, but then it's come now, and I feel really great and a lot lighter.
Better late than never. That's what they say.
Yes.
She just talked about side effects. Are there any side effects?
Well, it's probably worth saying a few words about the procedure itself, because this is what we call interventional radiology. It's not a surgical procedure.
Okay.
It's done by an interventional radiologist in our cardiac catheter lab. And it involves a little bit of local anaesthetic to numb the skin in the groin, and then a little wire is passed into the blood vessels, and it goes up and around the circulation, and it's quite a clever trick to sort of guide the little wire into the blood vessels which are feeding the fibroids. And then a special stuff is injected to block the blood vessels feeding the fibroids. So it's the procedure itself takes about half an hour or so, and patients are with us usually for one night, sometimes 2 nights, mainly because after doing that, the procedure itself is painless, but it causes a lot of pain for the first few hours after the procedure. So we need to have patients in hospital to have quite strong painkillers just for those, that day or so, until the intense pain is controlled.
Kind of goes down.
So it would be difficult to have the procedure and just go home straight away, because that bad pain would be kicking in. And then the recovery time is something like 1 to 2 weeks. It seems to people get the shrinkage, they're aware of the shrinkage quite quickly. I mean, perhaps Florence can tell us how quickly she was aware of that, whether it was...
Actually, after about a week, I started noticing changes. Of course, I kept feeling, because I could feel it. It was so big, and all of a sudden, I don't feel that hardness on my abdomen.
Yes.
And I was very excited. Then after about a month, I began to feel that it's actually gone. And then within 3 months, I was completely...
You were done?
Yeah, done.
Dusted.
Yeah,
okay.
yeah.
because the shrinking does go on even longer. We usually like to scan people again. We do an MRI scan after about 3 months, and then an ultrasound scan after about a year. And the shrinkage, there's a lot of shrinkage in the first 3 months, but then it keeps on shrinking even up to a year.
Small,
Yes. So Florence was mentioning she heard some of the kind of possible bad things about surgery, and I think again, just to give the complete picture, it's important to be aware that all procedures have potential complications, and even UFE does have there are some unusual but risks that can occur, and very occasionally people do get a severe infection afterwards, which can lead to the need to actually do hysterectomy. That's quite rare. We think it's probably about 1 in 1,000. Cases, but it's just important as a medical thing. We always have to say, everything has its risks, and we can never say that anything is completely risk-free. Of course, when we're counselling patients about surgery, we like to discuss the benefits and the risks, and then similarly, as with UFE, we like to discuss benefits and the drawbacks.
Yes.
And I think the other sort of point that people need to be aware of is it's not so good. It doesn't improve fertility. So, for example, a patient who's got a fertility problem is trying to get a baby. Having the UFE is not going to make things better. It's not going to improve fertility. It's very good for period problems. It's very good for big, bulky uterus.
Yes.
But it's not our first recommendation for patients where the main problem is fertility.
Yeah.
And perhaps in that situation, surgery is actually a better option. So it's important to, weigh all the pros and cons in the individual circumstances while making recommendations.
All right. Professor Stone, thank you very much for coming through. Florence, thank you very much for giving us your experience, and we wish you all the best. Like Professor Stone has just told us, if you're a man, I think it's important for you to tell your wife, your daughter, your girlfriend, your mother, or even your friend on how to go about having routine checkups, because like they said, it doesn't have symptoms, but it can happen to you. Well, thank you very much for that.